Welcome to the inaugural lecture of Adjunct Professor Srikant Sarangi. My name is Pirkko Raudaskoski, and I functioned as the head of the assessment committee for this post. The other members of the committee were Professors Luna Dirking-Holmfeldt and Finn Torborg Hansen. And I just want to read aloud the summary of our evaluation, as it explains very well Professor Sarangi's appointment. The committee concludes that Srikant Sarangi is an adept scholar who has developed methodologies within professional, especially health communication, discourse studies, and qualitative inquiry, including research ethics. Thus, he provides a rich interdisciplinary methodological toolkit to approach some of the essential issues in communication studies that the humanities at Aalborg University will definitely benefit from. Srikant Sarangi is an internationally well-known scholar in applied linguistics and discourse studies and a sought-after plenary speaker in the most important international conferences in these areas. As a founding advisor, he has arranged several international COMET, Communication, Medicine and Ethics conferences, also in Aalborg, and held numerous PhD courses, many of them in Aalborg. The conference series testifies of his extensive knowledge of applied linguistics, especially professional practice, and of his long experience with interdisciplinary cooperation, both with academics and with practitioners. He is most qualified for the post of adjunct professor and is indeed a valuable resource for many staff and students, not just in the Department of Communication and Psychology, but in the Faculty of Social Sciences and Humanities. With these words, I give the floor to our adjunct professor, who is going to talk about communicative contingencies and the interplay of expertise and ethics in medical healthcare decision-making.
Thank you. Thanks, Pirkko, for those very evaluative, summative comments. It's as if the life is done. There's nothing else to accomplish. And in fact, this lecture is a way of looking backwards more than looking forwards about what has happened in my research life, my professional life. So not just studying professional practice of others, but studying introspectively looking at my own professional practice over the years. So this is an occasion, and great that it's being recorded so we can look at it later, what else I want to cover. So there's a lot I want to cover, of course, being an inaugural lecture. And there are certain things that I will not cover, as one would expect. So first of all, actually it might be some curiosity. That is my third inaugural lecture at Aalborg University. Not the first, and not even the second. And that could be unique. So might be something we can, when we open the bottle of wine, we can talk. What happened? How come you are third time lucky? And in preparing this talk, I wanted to capture both ends of the spectrum of my professional research life. I started theoretically with a very commonly used sociolinguistic notion of communicative competence, which of course is tied to performance. And more importantly, it's pragmatic articulations, manifestations at the level of intercultural institutional activities. So the medical healthcare setting is just one. It could be school, it could be law, it could be the business settings or anything. So these activity types and how competencies are performed, displayed, and assessed for jobs and things. So that was what theoretically I started with. And then it certainly more gradually moved towards not just competency, but expertise. So what I would call communication expertise, which is more than linguistic, semiotic, interactional competence. So there is a lot more involved in the notion of expertise from psychology, from sociology, cognitive science, rather than a very linguistic notion of competence. So that was a kind of a theoretical trajectory, if you like. And then at the more recent end of the spectrum is my interest in ethics. And this ethics positioning is not just about research ethics, the regulatory procedural GDPR, but what I have come to call communication ethics, much more theoretically conceptual, and I'll try to elaborate that. So what I will try to do later is to show the interplay between communication expertise and communication ethics. But the context will be decision-making in the healthcare setting. So I'll stay focused on decision-making, which is both an everyday issue. Should I bring the jacket or should I not to work? Should I take the umbrella when going shopping or not? So these are decisions that we make on an everyday mundane sense. But more importantly, they are what are the life worlds of organizations, whether it is law, medicine, healthcare, wherever we think about. Decisions are made, and much more importantly, in the current climate, we are talking about shared decisions, not just decisions. And what exactly that means and what kind of expertise is required as a precondition for arriving at shared decisions. So healthcare professionals, patients, carers, institutional administrators, they're all making decisions whether to go and see a doctor, whether to call the ambulance service, whether to take a predictive test for my genetic status, whether to tell my test to others, my results, and who to tell. But also nurses are making decisions. Should they send the ambulance with siren or without? Or not send it at all? Should they send paramedics? So these are all decisions being made. Similarly, a doctor is going to make a decision about what kind of therapy and what are the alternatives that might be available or to choose from. So basically, shared decision making, or unshared decision making for that matter, will have different significance in different healthcare settings. So we can't talk about shared decision making across general practice and palliative care and genetics. So even when we're thinking about shared decision making as a kind of a basis, a premise on which healthcare delivery is offered, still there has to be differences across healthcare settings. So something I'll come back to, but we can keep that in mind. And decision making is very much a cognitive exercise. So a lot of cognitive science, psychology input into decision making. But it's also a communicative activity, and particularly when the decision making becomes shared decision making, so it has to be communicatively accomplished, interactionally accomplished. So that's what I think we'll talk about as I move on with the lecture, how this kind of a display of communication in relation to decision making requires expertise and ethics together, both in the embodied sense. What I'll exclude today from my discussion is expert systems, decision aids, the algorithms, the formulas, the more calculations of probability, and so on. So I'm not talking about, because that is what is a very interesting thing in itself, how experts and expert systems manage to calculate, and what are the tensions in that. Well, my focus will be on the interactional dynamics of decision making from a communication lens. So through communication, we're going to look at decision making. And in the spirit of this lecture being an inaugural lecture, and the contingencies of time, we started already a little late, but that's okay. I think I will refrain from any data analysis, even though that's my breed as a discourse analyst. I'll not do it. It's very difficult not to do it, but I'll try not to do it and only talk about it. But I will draw on two empirical settings to illustrate my discussion. The two chosen settings, one is genetic counseling in the UK, particularly to do with predictive tests for Huntington's disease and any kind of disease that are neurological, developmental, and no cure. but tests are available even if there is no cure for it. So that would be one area, one empirical setting. The second one is what we're doing here, the medical emergency calls, 112 in Denmark. And these two settings couldn't be any more different. And that is why I've chosen them. One that I started my life in the 1990s, and I'm ending with emergency calls. So these two more or less shows my core interest in decision-making in these settings, which are very diverse, but we can bring them together conceptually to understand what is involved as a communicative activity in this decision-making context. So in the genetic counseling context, actually it's better to call not consultation, but conversations. They just go everywhere. They talk for at least 45 minutes. And there are many occasions, it goes beyond 1 hour, when the clients would say, what a waste of time, and they leave the room. They didn't get an answer to anything. There are no answers to be given. Very ambivalent, very uncertain. So no wonder they leave frustrated. But the counselors want to make it as reflective, deliberative as possible. So conversations are important. Whereas conversation is not the preferred option in an emergency call. No conversation, only communication as transfer of information. Very small questions, very brief answers, because it shouldn't go more than 2 minutes. Actually, in most cases, less than a minute. And these differences across these two settings are communicatively manifest. So I'll keep coming back to this communicative aspect. So as you would expect, the EMS calls, the 112 calls, are very sequentially structured. Questions, answers, and so on. It only deals with the immediate scenario, the present, immediate present scenario. Whereas genetic counseling is much more about experience, narratives, reflections, hypothetical scenarios, what would you do if? None of that happens in the EMS. That's already very interesting to see that we can just look at, take a stab at the transcripts, and we can see certain things are more salient in one, not in other, but decision making is happening, and both are medical decisions. So these different communicative formats, question answers and reflective narratives and so on, actually show the professional practical ideologies. So genetic counseling is premised on non-directiveness. So non-directiveness is the holy grail of genetic counseling, because there are no answers to questions. EMS is very directive, because actions and decisions have to immediately be made, because life is at risk. So genetic counseling is not about life and death, it's life and life. EMS 112 is about life and death. So no wonder it shows that the nurse professional, as call taker, has to be very directive. So we can't accuse them of being too paternalistic and directive and so on. That is the nature of the job. That is what the decision making involves. In genetic counseling, non-directiveness would be the basis of having the conversations. But both settings involve decision making. But what we have to remember in genetic counseling, it is not the genetic counselor who makes decisions, it's the clients who make decisions. In collaboration with the family members, partners, and so on, precisely because the genetic condition is transmissible. Everybody in the family and close-knit family are at risk. So they are part of the decision making. Whereas in the 112 calls, it's the nurse professional as call taker who has to make the decision. And it's not a shared decision. So one is a shared decision from the family and the client in genetic counseling. The other one is not shared, but following the stipulated guidelines, the algorithms, and the protocol. Interestingly, call takers are not supposed to make medical decisions. They're not supposed to make diagnosis. They have to still send ambulance. They have to assume what might be wrong, whether it's the heart or the blood vessels or something else, but they can't, they're not supposed to, they're not entitled to make a medical decision. But the questions and the information that they deal with are all medical. So for the caller, the one who is making the call, it might look like a medical decision, even if the call taker is not supposed to make one. In both settings, it is not just medical information that travels, but also familial, circumstantial, life world. Things must be discussed. And the familial life world issues are pretty important in genetic counseling because of transmissibility of genetic disorders. So we have to know all about the families, the extended families, how many times they have been married, and so on. All these are important. We need to know. In 112 calls, such information is also important because they can help in deciding whether the ambulance should come very quickly, if there is nobody caring, there is no other person co-present. So decisions can be influenced by this familial circumstantial information, even though it is very medically grounded. So I just want to summarize this, but I don't need to go through this. I think basically what I'm saying is, in genetic counseling, it is the client who makes the decision about when to test, whether to test, who to tell that you are testing, and therefore who to tell that your test results have arrived, if it is positive or negative. So each situation is uniquely variable. Okay? And because it is so unique and so variable, there are no protocols. There is no algorithm to follow. Interestingly, with EMS, it is the opposite, that we find that because it is very standardized and there is a protocol to be followed, as I said, it is the call taker who will make the decisions, following algorithms and procedures, but of course the caller is an integral part of this process. Unfortunately, there haven't been any studies, as far as I know, but when callers decide to pick up the phone and call 112, we don't know, because that's a very crucial decision. And that is where if they don't call and delay, then the outcome is going to be very, very bad. But we don't know, because that's a very difficult way to access exactly how callers make decisions about making a call. Okay, so that's the preamble. Here I come to my main course, and I'm calling it Unpacking the Title. In a proper conference presentation, this means I simply unpack the keywords in 2 minutes, in 2 slides. But unfortunately, this is the main course here. It's not the appetizer. And this main course has 4 components, as you might have seen from the title. And these are the 4 I will go through in the rest of my talk. Communicative contingencies. I think I've already alluded to how decisions have to be made contingently, on the spot, here and now. What counts as decision-making and shared decision-making? Well, that's very controversial. And then finally, I'll come to what is implied in terms of expertise and ethics and the interplay between those two. So we'll go through these in the rest of my talk. So first, communicative contingencies. And many of you would be familiar with social interaction as being a kind carrying the 2 essential properties. One is contingency, one is emergence, and the other is relativity. It is something that was very well written about by Peter McHugh back in the 1950s. The book is a very classic book called Definition of the Situation. It's a very ethnometrological kind of a gloss on how situations are defined by participants. Okay, that's nothing unique to us, but he points out, following George Herbert Mead from philosophy, to come to that. So George Herbert Mead, who wrote a classic book, I'm still trying to find it, and even Denmark doesn't have a copy. It's 1932, The Philosophy of the Present. So I'll just try to summarize a little bit of that, where he talks about these 2 concepts, emergence and relativity. So these are the conditions of knowledge upon which action rests. So basically, it's about knowledge-based action. Knowledge-action interface, if you like. So that's what we're talking about in any situational encounter. And emergence and relativity both create and limit the possibility of knowledge. Emergence concerns temporality, time, sequentiality, if you like. Where past, present, and future intersect, they're analytically distinct, but very much inextricable. They are all in each other. Relativity concerns spatiality, not temporality. So this is across settings, across events. And here is a very brief gloss from Herbert Mead. When he talks about the philosophy of the present, he simply says decisions happen in the present. But we can't ignore the past and the future. And decision making is both happening in the present time chronologically, but also socially, social interactionally, if you like. And these sequences, chronological and social sequences of meaning, are not in one-to-one correspondence. The past is selectively invoked to make the present decision meaningful. So only some parts of the past will be used to make the decision in the present, which has consequences for the future. So now you can see, going back to the two settings I had set out before, genetic counseling and medical calls. In both, we have the past, present, and the future. They intermingle. The process of emergence is in the present, where the past and the future intersect and are reconstructed to make the present decision meaningful. So clients making a decision about doing a predictive test, or nurses making a decision about sending or not sending an ambulance. And actually, most of the calls end with, is it okay for the ambulance to come without siren? Because that's very crucial. That shows the urgency of the call. So that also has to be part of the decision at the moment. And this also connects with Alfred Soot's notion of etc. assumption, but also Garfinkel talks about it. What that assumption really means is the assumption that the future events will happen like in the past. So all calls will be the same. All things will be exactly how I have experienced. So professional practice is not a tabula rasa, you start all over again. So there is a pattern recognition that you draw on, and you expect that to be happening again with each call, with each consultation. So call takers, when they're handling the call and making decisions, they're likely to use this assumption. Okay, I'll do this because it will be like what has happened in the past. Algorithms are also premised on that already, based on those kind of evidences from the past. So from a communication perspective, we can try to unpack how is this etc. assumption actually played out in interaction sequentially, emergently. Could it be because of the way questions are asked in a chained way? Could it be because certain response tokens are preempted? So now we can see that this etc. assumption can be manifest communicatively and interactively. And this contingent aspect can be linked to the Nobel laureate Daniel Kahneman's work on thinking fast and thinking slow. So contingency means thinking fast. You don't have time to think and permute and compute all the possible alternatives. And the examples are really about firefighters. Firefighters don't arrive at a scene and calculate all the possible algorithms before they start. So they do things intuitively. And that's what thinking fast means, to do things intuitively without any voluntary discussion, deliberation, and so on. So it involves two systems of thinking or reasoning. The first one, thinking fast, it's something very quick with little or no effort and no sense of voluntary control. So that's intuition, and I'll come back to that later. System two is opposite. So you go through a lot of effort mental work and do all kinds of complex computations. So therefore, this is often associated with agency, choice, and concentration. So you have to really concentrate, work out what needs to be done. So that was the communicative contingencies. Now I move to decision making and shared decision making. As I've said, it's a very everyday affair, but it is also very important in institutional professional settings. And given the spread of how and where decision making happens, it's not surprising that many disciplines are involved, contribute to the study of decision making. Mathematics, psychology, philosophy, cognitive science, sociology, economics. And in fact, economics versus psychology is an interesting battle about what is rationality, but I will not go into that. Given this distinctive disciplinary perspective, decision making is characterized in many ways, whether it's a means-end logic, whether it is risk versus benefits, so therefore benefits outweigh the risks, but in most cases it is actually risk versus risk. That any medication we take always is going to have some side effects, so it is risk versus risk. It's not really risk versus benefit. Whether we should vaccinate the vulnerable groups, the younger children, teenagers, because it is risk versus risk. And it draws on computational mathematics, mathematical logic, statistics, and probability. And probability is probably the most important one in the context of decision making and risk. And Mary Douglas, the anthropologist, said any form of risk analysis is actually to turn uncertainty into probability. Then it gives it a scientific credibility. So you can't talk about uncertainty. I don't know. If you say 1 in 100, good. Even if that means you don't know or you are not sure what you mean by 1 in 100. So giving a figure, a percentage, some kind of a probability is always seen as credible, scientifically, medically, and so on. And the philosopher Reichenbach talks about two types of knowledge, what he calls certain knowledge, definitive knowledge, knowledge about certainty. We know for sure. But there are many things about the future we don't know. And this is where we need probable knowledge rather than certain knowledge, because we need some kind of knowledge to be able to make decisions about the future. So when we are not having any certainty about what might happen, whether it's climate change, the vaccine, or whatever, we have to use probable knowledge, knowledge in its probability. Even though probability means nothing to individual cases. Probability is about the collective, the population. A bit like evidence-based medicine. It's about the population. It doesn't mean anything for individuals. So since probability is about the population, society at large, it means nothing at the individual level. Or more importantly, and this is Michael Polanyi, who says probabilities cannot be discredited with experience. So individual experience, if it doesn't 1 in 100, if you are not the one, it doesn't mean 1 in 100 is wrong. It's just that you are not the one, or the 99 is right. So it can never be refuted through experience. So it's a kind of knowledge that cannot be refuted, which is amazing, the power of probability. The power of numbers during COVID, the rhetoric of numbers, that's more important than individual subjective losses and their life words or whatever else. That doesn't matter. Tell us percentage. So probability is always going to be still there, even if your experience doesn't quite align with it. And Polanyi gives this very interesting example. It's like training a dog with a statement, here, will you come or not? So however many times the dog comes to you, you can say the dog is perfectly trained because it understands the expression or not. But if you say, will you come, and it doesn't come 10 times out of 100, then the probability is less. So here, and particularly in genetic counseling, one of the outcomes is called 50% risk, 50-50. It's a little bit like playing the Who Wants to Be a Millionaire, 50-50. So when the counselor says your risk is 50-50, it actually means nothing. Your probability of getting the disease is as good as your probability of not getting the disease. So what is it telling? It cancels out. But it's still some kind of a normalization of risk that people say, okay, so I have 50-50 risk, and people accept that. They normalize it, and this also means something. Now moving more to very classic studies of decision making, particularly based on rationality. So rational decision making coming from economics. So rational actor model as coming from economics, but also from psychology, but they differ about what counts as rationality. But decision making, to me, is a relational concept. We really can't understand decision making without understanding what is indecision, what is a non-decision, and what is a decision by default. In many institutional settings, if we think about even today in everybody's institutional life, you might have left the workplace Friday evening with a non-decision about courses, classes, this or that, whatever. What is interesting is the non-decision by default becomes the decision over time. Indecision is different from non-decision. So we need to understand, and the same things apply to decision-making, shared decision-making, on-shared decision-making, informed decision-making, and so on, that I'll come back to. Also, there is some confusion. Some people try to see choice as synonymous with decision. I chose this, meaning I decided it. But choice is not the decision. A decision is the cumulative sequence of choices. Actually, if you want to be very, very precise, a choice needs a chooser, a subject, an agent. A decision can happen without a decider. Right? So we can make choices, but the decision might be something as a cumulative result of the choices that are made, rather than making the decision by yourself. Also, decision making is connected to belief systems and personality types. It's the classic book, which Aalborg University Library also doesn't have. I think I'm having very interesting conversations at this new library where I've vacated my office. I walk into there almost every day, and they put their hands up, say, we don't have, and we don't know where is what because we are just back from holidays, and it's a new place. So the day I went to look for George Herbert Mead's Philosophy of the Present, they said, oh, that's too old, 1932, no way. So not in Denmark. And this was 2012, 2011, we also don't have this one either. So anyway, what Groupman and Hatchman are talking about is people, and fascinating, it's called Your Medical Mind. It's a very useful read for all of us, both for doctors and patients and people, carers as well. So basically they identify two types of people, two types of patients, what they call believers and doubters. The believers are maximalists. They want to maximize what healthcare can offer, what technology can offer. They're the ones who must be Googling every minute and every day. These are the believers. If you are a skeptic, you will not do that. The doubters are the minimalists. And these believers and doubters do make decisions with the same medical facts very differently, of course. So that's not surprising. And when we talk to technology like internet and so on, both for healthcare professionals, and there might be doubters in healthcare as well as believers, they also use the technological affordances that change the trajectory and the nature of decision making. So there are two very different ways of looking at decision making. One is the very experiential, cognitive, heuristic model that I talked about as intuition and as fast thinking. The second one is much more rationally algorithmic, computational, the so-called decision support systems. So those are the two very broad traditions. But when we come to communication and decision making, it is very difficult. It's very slippery. And Deirdre Borden, back in '94, said when she was studying the book Business of Talk, looking at American presidential meetings and those very highly institutionalized meetings, they're meant to be decision making, but the word decision never appears, and it always escapes. So decision, even if a meeting is called decision making, decision itself is not a word you notice in the meeting at all. So it either is dispersed or elusive. But what we can find are these synonyms: problem, option, choice, preference, consensus, and so on. So there are alternative words that are used, but they probably index decisions, but not necessarily pointing a finger on that is a decision that we made. So decisions happen in minutes, written notes, rather than in the meeting, in the spoken word. And quickly moving to shared decision making, and that is what is now the dominant paradigm, particularly in healthcare, to move away from paternalistic traditional models of patient-doctor relationship. But it also makes a shift from rationality to relationality, that we should be talking about these things in relation to, rather than as rational individual human beings, autonomous decisions. But there is a lot of confusion about terminology, and I simply mention these. But what is shared, what is unshared, what is informed, what is imposed decision rather than informed. And these are very important for us as communication researchers, but they're equally important for practitioners and patients, whether the decision was shared, in which case they will follow up the therapy, or was it the doctors? My neighbor here, before I left, lockdown and so on, I heard that he had some problems, and one of the doctors said he had to be amputated, one of his legs, from the knee downwards. And he had the benefit of doubt and went to get a second opinion. And the second doctor said, we will only ampute your toe, not the ankle. So that's where you can see that whether a decision is shared, unshared, understood, informed, can be very difficult and nuanced. But basically, STM is about giving patients choices and options, safeguarding their autonomy, but at the same time, also professionals have to position themselves because of their expertise and what they know. So it is an ethical issue. It is often can be called a God term, which really means you can't refute it. Shared decision-making, democracy, human rights, you can't oppose these things. So these are called God terms. We have to live with them. And what we find is sometimes options, giving people options may not actually result in better outcomes. But the more options you give, the more confused the patients might become, depending on their literacy levels and understanding and so on. But also what Anne-Marie Moll calls illusion of choice. You say you can take this or this or this, but they're not actually equal choices. One is if you take this, you will die tomorrow. That's not really a choice. So then it comes to you take this medication or you take that medication when you die tomorrow. This one you live for as long as you can. Is it a choice? It's not. So that is where she calls it illusion of choice. And it's not a new concept either. Shared decision making has always been, and I have been tracking this from the 1950s. Basically, it's about the relationship between the doctor and the patient, the therapist and the client. And you can see that there are different models, and I will not talk through this. I just want to show how many models of shared decision making have mushroomed over the past decade, 2 decades. You can see the very last one, mutual participation, would be seen towards shared decision making. Here is another model from 1972, engineering, Priestley, collegial, the contractual model. So decision making, shared decision making is a contract between the therapist and the client. And what they try to emphasize is patient participation and involvement. So therefore, it involves relationships and responsibilities, including the notion of the expert patient, that the patients, of course, are becoming experts through their experience, particularly patients with chronic illnesses. So one classic book was called Meeting Between the Experts, back in 1985. Basically, the authors claim that because of the gap in competence between the patient and the doctor, shared decision making is impossible. We can talk about it like a God term, but it actually doesn't happen. We can't find it anywhere. It is not going to happen because the conditions for shared decision making cannot be met, the preconditions. And I'll skip that. So this is what it requires. To arrive at a shared decision making, both parties have to fully engage in the process of deciding, sharing emotions, feelings, values, arguments, in which case one consultation should take 3 hours, not 6 minutes or 8 minutes. How can we do emotions and feelings in 8 minutes? So it's not possible. We cannot provide the preconditions. We can talk about ticking the boxes. Was it a shared decision? Yes, tick. And these are some of the models. I just want to show how much of work has been done. I'll not go through this, but here you can simply see the notion of informed decision making is much more empowering than shared decision making. Okay. So if we're talking about high level of patient's power, patient's agency and empowerment, then we should inform them about all the things. We should arrive at shared understanding, not shared decisions. So shared understandings through information transfer or exchange, then they make the decision. So the client makes the decision. It's not a shared decision, but it's an informed decision. And these are very interesting points where the models show that how it has to follow certain steps. I find it fascinating. The final stage is said, a decision is made. Remember, there is no agency. So a decision happens. So neither the patient nor the doctor make the decision. Therefore, it's a shared decision. So I don't want to go through this. I just want to show how these have been constructed as very stepwise models of shared decision making. More of that. And this is one of the ones that is classically used by one of my Cardiff colleagues who's now in the US. They talk about 3 types of talk: choice talk, option talk, and decision talk. They're easy to label, but it's very difficult to find them in the talk. Notice that step 1, choice talk, is described as when patients know that reasonable options are available, but option talk is next. It's not part of the choice talk. So it is not easy, both for professionals and patients and analysts, to clarify what is choice talk, what is option talk, and what is decision talk. And I've already said before that many people take decision talk as choice talk. So such labeling is not going to help in understanding the communicative, interactive, the contingent aspects of decision making. And many of the studies are about treatment decisions rather than about patient outcomes and the whole process, but also some preferences, patient preferences might be very different. Some patients may not want shared decision, they want you to make the decision for them. So this is just to show that many of the studies have given us models. We have come across during COVID modeling a lot. So there are models available, but I think there is a very inherent paradox in these modelings. All the studies claim they're based on empirical data, hundreds of hours of transcripts, videoed and audioed and so on. So they say the models derive from them, but the models don't apply to the next real life encounter. That's the paradox. So how can a model derive to get a protocol, to get the steps, but once you try to apply it, and doctors say this all the time, but I can't practice it. I can write a paper about it. That's not difficult. But I can't practice it at work. Glyn Olwyn, my colleague in Wales, I remember that when he was taking some of my courses in qualitative research, his colleagues hated him because he wanted to practice shared decision making in 8-minute GP clinic. He's a GP. So all other colleagues had to pick up his load because he's doing one shared decision making clinic, which takes 40 minutes. So he should have seen 5 patients by then. So other colleagues hated him because they had to pick up the dirt, as it were. So you can see that talking about it is much easier than actually practicing it. So that's what I find, that communication is presumed rather than engaged with. So there is a lot communication research can contribute towards shared decision making, and there is very little of that. There are two problems with this modeling of any theoretical models and paradigms. One is they always remain abstract, despite their claim that they're based and grounded in empirical, concrete material data. And the second one is they're selective. They're not just abstract, they're very selective. And this is a fascinating way to think about all conceptual models and frameworks. It's almost like a fishing exercise. And like any fishing exercise, you have to be aware of the fishing nets, how it is designed to catch what kind of fish, in what kind of ponds, at what depth. And if that is not aligned, then the fish will escape. You're not going to catch anything. So there is always going to be something outside the model that the model cannot capture. And that's true of any modeling and also true of shared decision making. So I move to the more communicative aspects of shared decision making. And basically, many communicationists, and there are not that many, communication researchers, they do not use the term shared decision making. They would rather use terms like participatory, non-participatory, or something much more lateral, bilateral, rather than shared or unshared. So we can see shared decision making in communicative terms. I just have listed many things that we can look at: question answers, topic, role management, agenda setting, and so on. So there are ways in which we can have a communicative net to capture the decision fish. Okay? But still difficult to say whether it is shared or not. But we can deal with the decision-making process. Also, shared decision-making can be ethically looked at, rather than just the steps that we have talked about. And this could be both what happens before the doctor meets the patient. Decisions might have been made in the corridor at the coffee room. They only tell the decision to the patient, which test will give you, or having done the test, what treatment will give you. The decision doesn't happen in the clinic. So our way of looking at the clinic for health communication is wrong-footed, because if it is decision-making or shared decision-making, because that doesn't happen in the corridor. Sorry, it doesn't happen in the clinic, it happens in the corridor. So the backstage rather than the front stage. But the ethical issues about the public good versus the autonomy of the patient. Should we do this because it is socially good, collective good, or because this patient is demanding it. And it becomes even more problematic when we have consumerism versus autonomy. Patients demand they're consumers of healthcare rather than exercising their autonomy and social justice, if you like. Patients' rights is not the same as what is in their best interest. When it comes to best interest, the doctor might know better. When it is what the patient wants, their rights, then the patient knows more than the doctor knows. So these are ethical issues that have to be somehow reconciled, but also the patient versus the family. It is not the patient, like in genetics, for instance, or even in 112 calls, the carer is as important as the person who needs assistance. So can STM sit comfortably with the principle of do no harm? Because that's the basic baton that all doctors have to obey by, the Hippocratic oaths. But if we allow shared decision making to creep into decision making, then you might be doing harm to the patients because they wanted, they thought that is the right. They wanted this because they like the color and the taste of that pill rather than the other one. So shared decision making avoids some of the ethical issues because it is trying to democratize and try to, it's more like, it's a bit like, popularism that you might call in political circles. We can also see in healthcare popularism. That is a populist idea. A decision is shared, great. And when it comes to ethical issues, then we begin to find that there are some real thorny issues on these matters. So like I said, in the communication literature on decision making, the much more preferred terminology would be participatory, non-participatory, lateral, bilateral, unilateral, and so on. So they're talking about shared decision making, but not using the term shared because it has a baggage that comes with it, the GERD term. Participatory, non-participatory, lateral, unilateral, but we can analytically display that, demonstrate that. A very interesting study that shows, from a communication point of view, that actually patient participation can mean that there is minimal resistance to what the doctor is saying, but that doesn't necessarily mean it's a shared decision. So a consensual decision is not a shared decision. Okay? So what is consensual and non-consensual? What Egley and Barton and Egley call unethical persuasion. You can persuade people to make a decision, but that persuasion itself might be unethical. And very importantly, in the context of genetic counseling, because it is non-directive, their purpose is not to make a wise decision, whether shared or unshared, the right, correct decision, but to make the decision wisely. So to go through the whole process, if it takes 45 minutes, let's go through that. So going through the process wisely, and I think that means involving patients or clients to make an informed decision, not shared decision. And to get to the informed decision stage, we need to go through the whole process, the whole steps. So we can make a distinction between imposed and informed decision making. And some of the communication-oriented studies show that the doctor, by simply talking about certain things prematurely, might already be influencing the decision. So particularly, what are the benefits of this treatment? How quickly can you get onto this, like clinical trials and so on? Or let's look into what will happen in 2 months, 2 weeks' time. So the more you move things quickly, the more you are trying to attest your preference. And these preferences are very implicit, tacit, but they're happening nonetheless. And those are the kind of things that you could see as imposed, although implicitly, but they're imposed rather than informed. So there is another way of looking at it. Okay, let me skip one more thing. And finally, I just want to show one of our studies in the context of Huntington's disease. And what we looked at is, yes, it is useful to look at the steps. And we did identify problems, options, and decisions. We can somehow cut the transcript, the consultation into these pages. After that, we realized that these are not linear. So they're far more recursive. But not only that, we have to look at participant frameworks. Who is asking, who is formulating the problem, and who is responding? Is it the patient or the doctor? Then that can have a difference in what happens next. So we cannot just simply look at the stages of action, choice, option, decision, but the who behind those things. So the recursivity and the participant framework make it very, very complex. And what we came up with is, of course, decision making is emergent. It is not following the steps in a linear fashion, ending with a decision. And could it be that the decision is first made or implied by the doctor, by the healthcare professional, formulated by them, and then offered, volunteered to the patient for attestation, for compliance, for agreement? In that case, and we use that in our title of the paper, it is not a shared decision, it is a decision which becomes shared. The decision is made by the healthcare professional, and then it becomes shared because the patient agrees to it. Okay, I think I will come to the last part. I'll just skip a few things. This was summarizing some of the things I've already said. This is my final part. Have I got 5-10 minutes? I have lost track of time.
So have I. Yes.
Let's do it anyway,
Yes,
and then we may not ever listen to it.
Yeah.
I think this is the part where I signaled from the beginning I have moved away from communication competence to communication expertise in dealing with decision making, but also other aspects of healthcare delivery. And from research, regulatory, procedural ethics to communication ethics. So this is my kind of thing that I want to spell out a little bit in the context of what I've said before. So the first point I want to make is there is more to expertise than competence in communication, semiotic, interaction, turn-taking, or whatever. Expertise is more than competence or interactional communicative competence. Expertise includes scientific technical knowledge, experiential knowledge, ethical knowledge, organizational knowledge. So when we talk about an expert head of department, they know many aspects, not just one thing. So communication expertise constitutes not only knowledge about the mechanics of communication, that is a given, that is important, but it is not the only thing and not the sufficient condition for becoming an expert in any professional setting. Because for me, it is the channel through which all other forms of knowledge have to be communicated. The organizational knowledge, the ethical knowledge, the legal knowledge, and so on. So all those knowledge need to be channeled through communication. So communication is important beyond the modalities. And beyond codified knowledge, certified credentials, that we are all experts because I have a PhD. Okay, that is important, but that doesn't become the final thing in our expertise. So our expertise as teachers, doctors, lawyers, and so on depends on the epistemology of practice, going back to Donald Strong, or we can go back to Kahneman that I mentioned, what he calls intuitive expertise, based on intuitive knowing, or what Michael Polanyi calls tacit knowledge. So these implicit, tacit, ingrained things are the kind of things that we do fast thinking, and that's what expertise is. Like decision making, expertise is studied from various disciplines, and particularly cognitive science and sociology. And what we're noticing in the present times, contemporary societies, is a shift away from credentialed experts, those who are qualified, codified knowledge, to citizen experts. So citizens, the public, okay, public consultations, because public are experts. Mothers are experts about vaccination of babies, about nutrition, designer expertise, and so on. So people come, now throw leaflets into a garden, at least in the UK, they are tree surgeons. They're not gardeners, they're tree surgeons. So they want to do something to the tree that's almost like surgery, neurosurgery. So these are technologies of expertise, and I'll just flash out two things. Two very classic books in the past couple of years. One is called The Death of Expertise. So even when we're trying to be experts, expertise is dying. The notion of expertise cannot be sustained. So don't try to be an expert anymore. But we try to achieve more expertise, more specialization, more unified, molecularized knowledge. Actually, expertise is dying. It is dying because of technology. So technology is a big threat to expertise. And I did not talk about today on expert systems. That's what I mean. So expert systems are going to make experts redundant. The algorithms, the medical decision making is already happening. People trust the decision making systems rather than their consultants. So that's what is going, because technology is more reliable, it is mathematically right, it has no bias. At least that's the argument. So what is happening here, that there are attacks on expertise, obviously, because of the internet. Internet is everywhere, it is pervading. And the undisciplined nature of conversation in social media and 24-hour news, all these are affecting the notion of expertise. And this is when we're witnessing the death of the ideal expertise I like this expression, in a Google-fueled, Wikipedia-based blog sudden collapse of any division between professionals and everyone. People who are supposed to know and people who do not know. Now, people who now do not know claim that they are supposed to know. So then those who really know, they have no place. These are the experts. So that's the death of expertise. Another one, very recently, 2019, is the crisis of expertise. And basically it's saying the same, that the credentialed expertise is under constant threat, not just from expert systems, but also, and I was referring this to numbers, objectivity. The rhetoric of numbers, probability, so that's more important. So experts, whatever they think, whether vaccination is good or bad, is not important. What does the science say, not what the expert says. So mechanical objectivity, trust in numbers instead of subjective trained judgment, pseudoscience as opposed to sound science. So what we see here is lay experts, citizen experts, technology, all these are threatening the concept of expertise. And what we are beginning to notice is notions like clinical judgment, which is intuition, not the kind of arithmetic or algorithm. So that brings me to the communication ethics, my final point, that communication and ethics in discipline terms have separate lives. Hardly they connect or collaborate or dialogue with each other. But what I'm trying to say is both have shared interests. On the one hand, a commitment to ethical values will guide us towards very transparent communication. It's a bit like the Habermasian universal understanding. It is an ideal, but nonetheless is worth striving for. So it promotes a communicative mentality, transparency towards mutual understanding, and informed decision making. On the other hand, a communicative act is required to articulate what we mean by an ethical stance, an ethical position. So if I can't be communicatively ethical, what is the point in being an ethical being? So how can ethics be communicated, be a communicative self? And a communicative act articulates and mediates the beliefs and values that constitute ethics in any clinical encounter, whether explicitly, implicitly, or otherwise. We often say ethics is the science of ought to be, and communication is the science of each. Can ought and is be married? And I think yes. We can get these communicative aspects of ethics and ethical aspects of communication to come together. Actually, if there was time, I could talk about going to Grice and Habermas and so on, all these models of communicative action and the cooperative principle, they're all ethically grounded. They're not just communication. The maxims of quality and quantity and relation and so on, they're ethical matters. So is Habermas's concept of discourse ethics, although it's distinct from what I mean by communication ethics, but it does draw on Habermasian distinction between strategic action and communicative action. So communicative action is about intersubjectivity and universal understanding, the pragmatics of understanding. Strategic action is influential action, that you're trying to get the other person agree with your point of view. So that's persuasion. So strategic action is persuasion. Communicative action is universal understanding, much more intersubjective. So my way of thinking about communication ethics is every speech act, going back to the speech act theory, to John Austin and so on, is a communicative act. Speech acts are communicative acts. So they're communicative acts, they're also very strategic in the Habermasian sense. They're not naive and benign. So shut the door and close this. Would you mind if I left without doing anything? Would you mind if I don't cook today? These are not just understanding, these are strategic. It has impact on the illocutionary impact on people. So speech acts are communicative acts and they are ethical acts. So that's the equation that I'm trying to provide. So there are accountability and responsibility as part of communication. So what should I do? What would you do if it were you? What other people do under these circumstances? When you ask this question to the doctor, these are both communicative acts, speech acts, but they're very ethically charged. And how do we bring this, or how do we bridge the gap between communication and ethics? Is by focusing on the self or the relations, not rationality, but relationality, and role responsibility or accountability. So those have to be part of the ethics. Communication relies on this. We don't just self-talk. We don't talk to ourselves. So communication requires an other. So does ethics. So there is a huge amount of common ground between these two disciplines that needs to be bridged or worked more. And just to give a very simple example, is apparently simple questions in the clinic consultation. Is it your first pregnancy? Do you smoke? How is your diet, nutrition-wise? These are very probing questions. They sound very simple. They can be medically matter of fact. But is it my first pregnancy? I won't tell you, depending on who is in the room. If it is my new boyfriend, and I haven't told him I had another child from another boyfriend or husband, I'm not going to tell to the doctor that this is my second pregnancy. Do I smoke? It's the same. Because if it is going to affect the fetus, I better not say, even if I was a smoker before I met this man. So whatever it is that we talk about, so these are not simply a simple question. And one of the things I noticed in the emergency calls is when the call taker says, do you live alone? It's meant very nicely to manage what kind of help should be sent. But sometimes people react. Why is that question? Do I live alone? What has that got to do with you? So the idea that there is a carer, a co-present, who can make you sit or can open the window, can open the door when the ambulance comes, that's why they ask. But suddenly it takes on a very strategic and potentially ethical meaning. So that's what I mean by these speech acts, communicative acts, and ethical acts. So we can capture that in a kind of a communication remains central. We can talk about rights, choice, autonomy. I didn't talk about trust, but that's very important. Ethics, morality, and the two aspects that I have tried to emphasize, the relation, self and the other, and the role responsibility. So if you want dessert, that's the conclusion. I think I'll just finish up by saying the contingencies of decision making and their communicative manifestation, they defy any simple or rigid standard characterization across healthcare. So we have to be very careful. And we're talking about primary care, genetics, medical emergency, and so on. And within each given healthcare setting, each consultation will demand a different kind of ecological adaptation or dexterity. I think that's becoming a much more powerful concept, that it is flexible, there is resilience. And what my main point of departure has been is that in a given provider-patient encounter, decisions are not made and then communicated in a linear way. I think that's very important. But that it is through the communication process, decisions evolve and emerge in a contingent way and become consequential. So in other words, actually, the better you are as a communicator, the better you might be as a decider, or the better the quality of the decision will become, because you have intervened and responded and been aware communicatively throughout the process. So communication is criterion to good decision making. But it is not something that we make cognitively and then simply articulate communicatively. In adopting a process-oriented communication perspective, I have been very critical of the shared decision-making protocols, as I have shown, but these have gained much currency in recent years, moving away from rationally based decision-making and much more towards hermeneutic, ethical decision-making. And that is good, but it is still needs more work. And the model actually thrives on concepts such as choice and option, but actually not everybody goes for choice and option. Some people actually go for advice. It's fascinating that in the current literature, advice and instruction are not any longer researchable topics in medical encounters, because they are not shared decision making, so it should be looked down upon. Fascinating, but advice is happening in every clinic. But we can't study it anymore because nobody wants to claim they're giving advice or instruction. And as I said, from a communicative perspective, shared decision is more like a decision shared, as I informed. But of course, it has to be very much about informed decision making rather than shared decision making. And just to finish, is we can still try to conceptualize much of what I've said and capture the dynamics of decision making, both on two axes, consequentiality and temporality, with communication seen as expertise and ethics being only relevant. Communication is relevant. I'm not going to underplay the role of communication, but it has to be in tandem, in line with notions of expertise and ethics. And that would almost the kind of Aristotelian notion of phronesis, practical knowledge of the time, act as you should, what he called the doctrine of the mean, the best action given the circumstances in this particular point in time. And that's my final way of concluding, that keep in mind communication as omnirelevant. And the decision making will have to be on two axes. What are the consequences of the decisions you make now? And what might be still uncertain in the present and the future. Then along these two axes, you can have a medical intervention like neurosurgery, for instance, where the consequences are low and certainty is high, uncertainty is low. So that sphere of medical decision making requires as a precondition low consequences, low uncertainty. Then we find a lot more cases, chronic illnesses and so on, where consequences are much higher, more negative, not even beyond the individual, and uncertainties also scale up. So then medical intervention is not enough. Then we have to talk about clinical psychology, therapy, and so many other things, including self-care. And finally, when we move to the more moral, ethical issues, whether it is palliative care, I think I was intrigued. The author of the very best-selling book, Do No Harm, I forget his name. Yes, Marsh, Henry Marsh. He himself now has end of life. He wants assisted death, but it's not legal in UK. He is asking, being a neurosurgeon himself, on the top of the field, his wishes are to get assistance, physician-assisted death. That's not allowed. So anything to do with palliative care, end of life, or abortion, or whatever, I mean, those are the kind of moral, ethical issues. Actually, you begin to think whether medicine should be involved in it in the first place. Because they are beyond medical from where we see, because the consequences of those are far beyond what medicine can even conceptualize or anticipate or think of. So I will stop here. Thank you for listening.